fecal contamination of food or drinking water. Other factors could be like poor hygiene, improper handling of food, crowded situations, poor sanitary condition factors.
Yes. Good, Shay. Yes. Yes. Very, very good. Okay. So your patients, how would they come in? How would you guys see this if they are coming into the hospital? Say you're like an ER nurse. What symptoms or manifestations would we see with these patients?
Jaundice, flu-like symptoms, low-grade fever.
Abdominal pain, fatigue.
Okay. A big one with these, it's crazy, but anorexia. They come in like lack of food with hepatitis. It's like hepatitis throughout the whole A, B, C, all of them. They tend to have that anorexia. They don't eat. Yes. Not wanting to.
You said anorexia for all of them?
A lot, hepatitis like across the board, yes. So it's transmitted that fecal oral route, yes. Good, all right. Symptoms here, manifestations usually is that anorexia, that loss of appetite, the flu-like symptoms. All right, so how do we diagnose hepatitis A? And this is kind of throughout the board too.
Isn't it blood testing for the
liver
IgG and IgM?
Yes, blood testing for hepatitis across the board is how we would measure them. So we're looking for that anti-HAV, that immunoglobulins. Yep. And again, with hepatitis A, another big diagnostic test, or how we would diagnose these patients is, what could we ask them? If they're coming into your ER, what would we want to ask?
Have you recently traveled outside of the United States?
Yes, yes. Have you recently traveled? Okay. So nursing care, how do we care for these patients? You're caring for them.
Bed rest, nutrition, avoid alcohol.
Yep, stay home, stay in, do not leave. It's kind of like we're doing right now, right? Stay home. Yes. Nutrition, eating those small foods, just so they're getting enough calorie count, avoiding that alcohol. Yep. All right, so treatment, and let's start with treatment here at prevention. What can we do for hepatitis A?
Wash your hands.
Okay.
Proper food preparation.
Yep.
Vaccinations.
Vaccinations. Okay, hepatitis A has a vaccine. Yes, we want to give that vaccine to prevent any type of community outbreaks, to prevent any type of outbreaks. Again, good hand washing, somebody had mentioned, standard precautions, right? Hand wash. Using that household bleach. If your partner, if you live with them, it's so important if the patients, you send them home and they're living with family members, right? Telling them you need to kind of avoid them, kind of seclude yourself. Again, it's kind of like what's happening right now. We need to seclude ourselves, not share anything with them. With your husband or spouse or anybody, like no kissing, no any type, like safe sex, avoiding it. Avoiding any type of close contact, basically, until everything starts to resolve. All right, so that is hepatitis A. Everybody feel okay with A? Okay, let's move on to B then. What's the pathophys of B? So we said A was it's the RNA. What is B?
DNA.
DNA, yes. B is the DNA virus that's transmitted through blood. Okay, but where else can we find it?
Mucus, saliva, sexually exposure.
Yep, good.
Bodily fluids?
Yes.
That's how I remember it.
Yes, yep. Okay, so who is the big risk factors for these, for hepatitis B?
The healthcare workers.
Healthcare workers, yes. Because why, Tyler?
Because we handle a lot of blood products and blood and needles and such.
Needle. Yep, needle stick injuries. Yes. For healthcare workers, it tends to be the needle stick injuries. You poke your finger, you're poking. Yeah, yep. Another big thing too, risk factor for hepatitis B, people to contract hepatitis B. So healthcare workers, what's another big one for hepatitis B?
IV drug users.
Yes, IV drug users. That's another big part of hepatitis B. All right, so it's transmitted that way. How do these patients present to you? What is their symptoms, manifestations going on?
Anorexia, nausea, vomiting, right upper quadrant pain.
Yeah, they kind of have a bit, don't they? And then this tends to go B and C with acute to chronic phases. I don't know if you guys were able to see that. So acute is that someone who's been exposed, it's like within the first 6 months for acute. Chronic, it usually lasts longer than the 6 months. So anorexia, yes, that tends to be the big one too with hepatitis B. They get that hives too as well. Jaundice, dark urine. All right. And chronic comes on slowly, right? Because it's like longer than 6 months. They tend to have fewer GI symptoms with hepatitis B. All right, so hepatitis B, how do we diagnose it? What are we looking for?
Is it the surface? Is it the surface antigens and the immunoglobulins?
Yes.
Again?
Yep. Those surface antigens along with the surface antibodies, right? Those two hand in hand. I'm not sure, have any of you guys ever had to get your hepatitis B to see your titers drawn? To see if you guys were immune, if you had the buildup of it? Okay. Yeah, some people do. I know I did when I first, and you may even, I'm not sure how they do it now, but if you get hired in as an RN, they're gonna draw blood on you. They did when I was just yesterday, right? They drew my blood to see if I had the buildup antibodies. Yep. All right, so some of those are your diagnostic tests with that. Okay. All right, so nursing care. How do we care for these patients?
Kind of the same, the rest, nutrition, clean your equipment between each patient very well.
Okay, yep, that's the big one for this as well. We need to clean our equipment. Gloves, right? Anytime we can use disposable needleless system, that's how this all kind of progressed too into the needleless system because of that contamination, the poking, the needle sticks. Yes, yep, needleless system, disposable equipment when we can. The goal, right? Interrupting that transmission of the hepatitis B. Okay, so treatment. Does hepatitis B have a vaccine?
Yes.
Yes. So that is the first and foremost, most effective method of preventing hepatitis B, getting them vaccines. All right, so how many doses of hepatitis do we usually get?
Isn't it 3?
Mm-hmm. When does it start?
Birth.
Yeah, usually birth, right? Okay. All right, so have you guys all received that hepatitis B vaccine? Majority of you? Yeah.
I think you have to be in the program, don't you? Because I think we have to upload all of our vaccines.
You do, yeah, yep. All right, everybody feel good with B? Okay, let's move on to C then. C, what is C? Patho. Is it RNA, DNA?
RNA.
RNA, yes. C is an RNA. It's primarily transmitted how? For C.
Percutaneously.
Yes, percutaneously. Like, give me an example.
Basically like any puncture underneath your skin.
Okay, yes. So a lot of these risk factors would be for who? What kind of patients?
People using the same needle, drug users.
Drug users, yep. Another big one for hepatitis C. The drug users injecting, yep. All right.
Like diabetics using the same needle too, right?
If it's somebody else's, right? Yeah. I hope they're not, but
Right.
yes. Okay, so some clinical manifestations. Oh, we did that. Symptoms. Again, these kind of go hand in hand, right? With B, with that anorexia, the nausea, vomiting. Tori mentioned something too that can happen with hepatitis C. Tori, what was it?
I don't remember what I said.
You asked me what was it?
Pruritus.
Oh, the fluminant hepatitis.
Yeah, okay. So what did we talk about? What is it? Describe it a little bit.
So you said it's a severe impairment of the liver.
It's very rare though. Yes.
Yeah,
it's
very rare. Did you say there was a mass on the liver?
No, massive necrosis. So,
oh, okay, massive necrosis.
yes, that can happen with C. Okay, how do we diagnose C?
Blood tests.
Blood test. Okay, what blood test would we look for with C? Now, there's not really a antigen, antibody kind of specific for this. So what would we look for with hepatitis C?
Liver function, like AST, ALT.
Yep, those liver function tests.
Bilirubin.
Yep. Good. What else? What else does the liver do?
As in like what?
Like the anti-clots, so like the increased PT?
Yes, yep, for clotting. So that's another thing that we could look at with hepatitis C. They're clotting factors. Okay. So what's the nursing care for these patients again? It's kind of the same, right? Nutrition, rest, modifying their high risk behaviors, follow-up testing, but let's emphasize on a well-balanced diet with these patients. What should we tell them that they should be eating?
Limited saturated fats.
Yes, limit that saturated fats. Yep, good. Okay. Treatment. How do we treat hepatitis C?
The 2 antivirals.
Okay, name one.
Interferon.
Okay, anybody know the other one?
Ribavirin.
Okay,
Virin?
yes. I know some of these, this might be who somebody is assigned these to for their medication as well. Okay, so these are the antiviral. They're usually used in combination. Response to this treatment is during the first 12 weeks. This will predict the probability outcome of a full 48-week course of treatment. So this treatment is quite extensive. What's the other treatment for hepatitis C?
Liver transplantation.
Liver transplant, yes. All right, moving on to D. What do we usually call D? What's another name for it?
Delta virus.
Delta, yep, the Delta virus. So what do we need in order to have D? What needs to be there? They like work together.
Hepatitis B.
B, yes, B and D go together, yes. So it cannot occur without B. Again, this is that rare, it can create that fulminant hepatitis with that rare syndrome. There's no vaccine for D, right? But how can we prevent D?
If you have the B vaccine, it'll help.
Yes, so get the B vaccine. Good, Shay. Get that B vaccine in order to help prevent D. Okay. Okay, moving on to E then. What is E? What's the patho of E? It's DNA or RNA?
RNA.
RNA.
RNA, yes. This is another one that's transmitted which route?
Oral.
Yeah, the fecal oral. So these are usually seen though in like India, Asia, Mexico, Africa. Again, it's from that contaminated water. We don't see much of it here. All right, so moving on to G then. RNA, DNA.
RNA.
RNA, yep. So it's a rare cause of the hepatic inflammation. Very, very rare. Again, I don't think I've ever seen any of these ones that we're kind of touching on here. It's characterized again like sexually transmitted or parenteral, found in blood donors. It coexists with other hepatitis. That's all I would just kind of know that there's a G. Okay. All right, everybody feel good with these? Any questions on hepatitis? No? Okay, so let's apply it. Let's do a case study and let's see how this is all going to work together. How we can use, I got to find it. All right, you guys, let's work on these together, okay? Can you guys read it? All right, so we have a 30-year-old man. He's admitted to the hospital with general fatigue, lack of appetite, headaches, and yellowish complexion. So right away, what is your giveaway? What do you guys think something's happening with him?
Yellow complexion.
Liver dysfunction.
Yellow complexion. So when we see this yellow complexion, we should be thinking what?
Jaundice.
Jaundice. Great. So symptoms become progressive during the past few days. 1 month ago, he was in Mexico, where he ate a lot of seafood and Mexican food. Physical examination indicates an enlarged, tender liver and icterus, what is icterus, you guys?
Wasn't that jaundice?
Yeah, okay. Good job. Okay, labs here. We have a hemoglobin of 12, which is okay, right? Billy 5.6, bilirubin of 3.4. So this is your direct and indirect. The alkaline ASTs and ALTs, and the urine is positive for Billy. Okay, what type of hepatitis does he have?
A.
A.
Why do you guys say A?
Because he's traveling doesn't really mean that much, but he's been eating a lot of seafood down there, and I remember in your slideshow or your voiceover, transmitted by food also, such as shellfish.
Okay, yes. So we know that hepatitis A is transmitted through the oral route. So fecal contaminated. So how did he get infected? You just said, right? He ate
Bunch of seafood down there, yeah.
Yes. So how do we treat, what is the treatment for hepatitis A?
Nutrition, bed rest.
Bed rest, yeah.
Okay.
And then avoid avoid ingesting things that might irritate your liver, such as alcohol, Tylenol, stuff like that.
Okay. Okay. What is the priority for his care?
Well, his AST and ALT are pretty high.
Okay.
So probably, rest the liver,
Yep, good.
rest your metabolic,
Okay. So what teachings are important to discuss with him?
Like
Don't-
prevention of like safe sex.
Okay.
Don't eat food you're not positive about, buddy.
Okay. What else?
Don't go crazy.
Hand hygiene.
And hygiene. Yep.
Self-isolation.
Good. Yes. Not sharing anything with his family. Good. All right. So let's see what. Good. Everybody feel good with that? Kind of throw it out there. Hepatitis. Any questions on hepatitis? It's kind of becoming rare. Everybody's usually getting those hepatitis vaccines, so you're not seeing hepatitis as much as you did before, but you still need to be aware that it's there. All right. Good. Okay. Let's move on then. How about cirrhosis? What can you guys tell me about cirrhosis? What is like the #1 cause of cirrhosis of the liver?
Alcohol.
Alcohol, yes. Has anybody seen have you guys cared for any patients that had cirrhosis of the liver? Tell me a little bit about them. How did they present to you? What were they like?
They were horrible. They were miserable, honestly.
Define miserable, like how?
Like their perineal cavity just like bulges up and they look like they got a big yoga ball in their stomach because of all the fluid.
Okay, talk to me about that fluid. What is that? What's actually happening to them?
So the liver is basically excreting plasma it's excreting fluids into the perineal cavity because of like the cirrhosis of the liver, all the scar tissue, the backflow of like the portal hypertension.
Yes, good. Yep, it's actually albumin rich. That ascites that build up in there is all like albumin. So if you've ever seen them do a paracentesis, if you guys hear that word, remember centesis is like draining that fluid. So when we talked like thoracentesis, remember it's draining the fluid off the lungs. So if you hear paracentesis, they're draining that fluid off the peritoneum. So with that, they will fill bottles upon bottles. If you guys ever get a chance to go and see them drain it, liters off of patients, but you can see their bellies are huge, right? So they're gonna have to drain off quite a bit of fluid. And it's albumin rich, and it's like this yellowish fluid that they're pulling off.
So since it's like albumin rich, does that mean, because I know albumin has like, it's got a big factor with like osmolarity and like fluid shifts, right? So since it's albumin rich, would more fluid be apt to go there, I guess, is what I'm asking.
When it's done, like when we drain it all off. Like,
well,
what do you
that's
say?
part of the
More
reason
fluid?
too. Like, is that part of the reason since the fluid is albumin rich, is that also part of the reason why there's so much fluid in the perineal cavity? Because it's like
filling there.
Over. Yeah.
Yes, but
Okay.
You mentioned it earlier though. Okay, it's a combination of fluid moves in from the vascular into that peritoneal space. Yes, but you talked about it. Why?
Because of the portal hypertension.
Yes, that's good to know, you guys, that portal hypertension. So it's fluid moving from the vascular system into that peritoneal space. Yes. That is what's happening with ascites. Okay, how else do they present, you guys? What else do you notice on patients that have cirrhosis of the liver?
Their eyes get a little bit yellow.
Okay.
Sometimes their skin. Do you always see, I've seen it where the skin gets almost like leathery. Is that normal or just certain people?
No, it can be. It's just the yellow, the billy coming through it. Dwayne, talk about your patient. His kind of goes with the gallbladder though. But just talk about how yellow he was.
He was very, very yellow. Like, And they do kind of have like a specific smell to them. Like,
That's what I wanted you to get out of this. Have you guys ever experienced a patient with cirrhosis with a smell?
it's not just like, it's like their skin, like their oils from their skin, their urine, their feces, like all have a specific smell to them.
And what do you think that smell is?
Wouldn't it be the bilirubin and the like proteins also?
Yes.
And
Yeah.
some of the ammonia?
Ammonia. Yes. It's kind of like that ammonia smell going on for sure. Yeah. That's the first thing you can notice with patients that have cirrhosis of the liver. If you are standing outside their door and just walk in, you can smell them, or talk. If you're talking to them, they have such an odor, a smell to them. Yes, it's kind of like an ammonia smell. Yeah. All right, good. All right, so I'm gonna just keep going here, right? You can have a fatty liver, right? They kind of call those the NAFLs, like the non-alcoholic fatty liver as well. Some of these risk factors for that is that fat concentrated in the abdomen. Remember, they kind of have that apple shape where their legs and arms are pretty skinny, but then they get that fat concentrated in there. So that can be kind of a cause of it. Type 2 diabetes, if they have high cholesterol, but also high triglycerides are the factor with the non-alcoholic fatty liver, the NAFLD, and high blood pressure. All right, so normal function of a liver. Let's talk a little bit about the liver and how it does function. The liver, I had talked with my group too, but let's talk about the size of the liver. When you guys think of the heart, how big is the heart again? Remind me.
A fist.
The size of your fist. Okay, so when we talk about the liver, how big is the liver?
It's not the size of a football.
Football. So can you imagine how big that is inside your abdominal cavity? So let's talk about all the functions of the liver. What does the liver functions? What do they do? What is the main purpose of the liver?
Filter out
Clotting and protein production.
Okay. Yep.
Detoxifying your blood.
Detox, yep, filters, right? Filtering the blood coming from that digestive tract before passing it into the rest of the body. Yep, so it detoxifies chemicals. What else can it do?
Produces bile.
Yep, bile production. So the liver excretes bile that ends up back into the intestines. What else can it do?
It stores all your clotting factors.
Yeah.
I don't know. Did somebody already say that? Maybe.
It's okay.
blood sugar, it helps maintain it.
Yeah, converts like the monosaccharides to glucose and stores excess of the glycagon.
It's an enzyme activator.
Okay. What else does it do? Stores what?
Blood.
Okay.
We already say like the proteins and the
Yep, we did.
carbohydrates.
Yep.
Okay.
So it manufactures albumin and other globulin components, clotting factors. Okay, so what else does it store?
Vitamins.
Vitamins, yes. So it stores your vitamin B12, K, D, A, E, copper, iron. So when we have problems with patients that have liver cirrhosis going on, or sometimes the alcoholics come in to detox, right, in the hospitals, what do you think is a big thing we would have to give these patients?
A banana bag.
A banana bag. I'm glad you know what a banana bag is. That's what we call them. I don't know if anybody's familiar with that term, but it's a yellow bag and it is full of like your vitamin B12s, your vitamin Ks, A, D. It has a huge, it's not huge, I guess it's just a liter bag, but yes, we do the vitamin bags for these patients. All right. All right, good. Okay, so just gonna keep flipping through because you guys kind of read about these. Okay. Any questions so far, you guys? I'm just keep going. Okay, portal venous congestion. Talk to me a little bit about that.
Isn't it when the blood flow gets backed up from the liver
Mhm.
and then it backs up into like the perineum area, and then it seeks an alternate route?
Okay, so what can that congestion, that portal veins, right? We kind of briefly touched on it a little bit. So it's obstructive blood flow. So when we have that obstructive blood flow, blood backs up into the intestines and the spleen, and it causes that congestion of the portal vein, which leads to what?
Ascites.
Ascites. What else?
Varices?
Yes, varices. Yep, and where can varices be found?
In the esophagus?
Okay, where else?
Can they be found in the stomach as well?
Yep.
Okay.
And where else? It's kind of basically your whole tract, right? Rectal as well. So the kind of the three spots, esophageal, gastric, and rectal. Okay, so we have that buildup going on, right? So we briefly touched on ascites. Let's talk about the varices, right? That portal hypertension creating the varices. Talk to me a little bit about varices, you guys. What is it? Like characterized. What do we got to watch for with these?
Bleeding.
Bleeding, a rupture of it. That's one thing we do not want. What happens if it ruptures?
Pretty much death.
You pretty much die, or you have to move super fast, right? It's the medical emergency. They have to come in. Yes, if it ruptures, the mortality rate's pretty bad. All right. There were pictures too, I know, of some varices. All right, let me move to it quick here. What's one procedure that we can do with the varice?
Barium swallow.
Okay, you can do the barium swallow to try to find it, right? Like, okay. So if we find it, what would we do?
Like a shunt?
Tamponade.
Okay, yeah. What did you say, Dwayne?
Balloon tamponade.
Okay, yes. So explain to me what that is.
Isn't it a balloon that they like insert down through your esophagus into your stomach and then they blow it up to kind of put pressure against those so that they don't rupture?
The bleeders, yep. Okay, so it's that Sengstein-Blakemore tube. It's kind of a mouthful, but that's the name of it, that balloon tamponade. It's inserted, yep, balloon inserted, inflated to alleviate or stop that bleeding. So with these patients, this is kind of rare. I don't think I've ever cared for a patient that's had this, but what as a nurse do we have to assess with this? Like, think about this. It's a tube going down, right? What do we got to assess?
Reflex.
I'm sorry?
Gag reflex.
Okay, they're going to have that tube down there. So chances are we're not really going to assess a gag reflex, right? Because the tube's already going to be down. We're trying to stop that bleeding. So
Breath
what as
sounds?
a, yeah, okay. Assessing the breath sounds. Yep, good.
Airway.
Airway, good job. Maintaining that airway, great. These are things that we need to assess as an RN with that Sengstein-Blakemore tube, that balloon tamponade. It's a temporary fix though, just kind of know that. In maintaining that airway and assessing those breath sounds. Okay, what else is another thing? How about this total portal division, TIPS? You guys can kind of see the slide of it. So the TIPS procedure. When we perform this TIPS procedure, it puts pressure on that esophageal varices. So what it does, it lessens and more volume is re-entered into the general circulation. So it's like a shunt. The shunt, it helps shunt that blood past the failing liver on its way back to the heart. When we do a TIPS procedure, this is a result. It helps to improve cardiac output. So when we think of cardiac output, what does this reflect? What gets better with cardiac output? Do you guys know? Like, this is just in general. This brings us kind of back to cardiac. Pull in that cardiac.
And what was the question again? How it
Okay.
affects cardiac?
Okay, so yeah. So when we have an improved cardiac output, what is reflected? What is better within the system?
And blood pressure was reduced
Okay.
and heart rate.
Okay. How about the oxygen? Okay. It helps with the hemodynamic function all around, right? So when we think of, cardiac output, it's going to help reflect and better that hemodynamic function within the body here with TIPS. That's what it's all going to help this procedure.
Quick question.
Sure.
My computer died, so I had to find the charger. Just where we at?
I'm going to yell at you like I yell at my children. You got to plug
18.
those in the night before. I'm just kidding. Okay. We're in TIPS. The TIPS shunt procedure.
Page 18.
Oh, thank you.
Okay, so let me reiterate this to you guys again, just so you guys can kind of get an idea of what this TIPS shunt procedure is. So it's pressure on the esophageal varices, which is lessened, and more volume is returned to the general circulation. So it shunts blood past the failing liver on its way back to the heart. This result, it improved cardiac output, which then will be reflected in better hemodynamic function. TIPS procedure. All right, so we touched on the varices, we did ascites. Let's talk about what do we do when we do a liver biopsy with these patients? Are they sedated? Are they? Do we actually put them under?
No.
No, they don't really need to be. No. Okay, so as far as nursing care with these patients, if we're not sedating them, what do they usually do? The physician will do this. So they numb it, right?
Yeah, is it a needle biopsy? Right?
Yeah, yep.
Like
They call it like a blind stick, a needle biopsy. So they go in, they puncture it, they get a little piece, they get a few pieces of it, right? And then as the RN, you're caring for them after, the aftercare of a liver biopsy. What do you think we need to do?
Lay on their right side and like pressure on there.
Yes, yep. So post-op, remaining on that right side. Sometimes we use a pillow in there to kind of brace it to why? Why would we use a pillow? Just like anything, like why would we put a gauze pad on a IV site?
To apply pressure, I mean.
Yes, to compress. Yep, compressing that liver against that chest wall because we want to decrease the bleeding. So putting him on that right side, putting a little compression on it. Okay, good. Okay, so I'm gonna just keep going. Okay, let's treat these patients then with cirrhosis. So nursing care, we have cirrhosis of the liver here. what is our goal? How do we treat these patients? What do we want to teach them? Let's start with teaching.
Stop drinking.
Stop drinking. Yes. Alcohol. Limit. Stop it. Don't take none of it. Okay. What else? How about diet? Tell me what kind of diet these patients would be on.
Like
A low protein.
Okay. What else?
Low fat.
Oh, I'm sorry. Low cal. Oh, okay. Is that what you said?
Fat.
Fat? Okay. Okay.
They wouldn't be eating like big meals,
Okay.
not 3 big meals a day. Try and break them up into smaller meals.
All right. How about any restrictions? What would we restrict?
Like
Tylenol.
Okay. Medication wise.
Like post biopsy, no heavy lifting.
Okay. How
Wouldn't they
about
restrict sodium?
sodium? Who said that? Good. Yes. So these patients too, they're usually on a 2 gram or less sodium restricted diet. Why?
Because fluid goes where sodium is.
Okay. So it's kind of that fluid shift, right? All right, good. Yes, restricted. This helps to prevent what?
Further ascites or edema?
Yes,
No.
good job. Yep, perfect. Good, good, good. So restricting that sodium, low sodium, yes, to help prevent ascites. Usually these patients too, they're also on a diuretic, but they have to be on a diuretic and restricting that sodium as well. Okay, so another thing to think about with treatment. What else do we got to okay, so we did diet, bed rest, right? How about antibiotics? Why would we do an antibiotic with patients with ascites?
Because they're more susceptible to infection.
Okay, what infection in particular?
Peritonitis.
Great, yes, spontaneous bacterial peritonitis. Good. All right, the bed rest, and then we talked the paracentesis, and then that TIPS procedure. All right, so those are some of the treatments that we would use for cirrhosis. Some. Okay. Moving on then to some of the causes, and again, we did ascites, so let's get into hepatic encephalopathy. Yes, anybody ever hear of that? All right, Dwayne, you're raising your hand. Tell me about it.
So I've experienced this. It's when their ammonia levels get so high that they are just like, they're way out there.
Okay. So it's confusion, huge, right? So what happens with ammonia? What is actually physically happening with them?
Doesn't it like travel to the brain?
Yes, it can cross the blood-brain barrier, the ammonia does, yep. And it can cause changes in that cerebral function. So they get really, really, really confused. So how can we know if they have this?
Lab test for ammonia levels.
Okay, yep, let's lab test it. Let's see their ammonia levels. Do you guys ever watch the show Transplant? Is that what it's on? It's kind of on TV. It's a young doctor, and it was just on, it's like episode 2. So the lady was yellow. He walked into the room and he said, put your hands like this. What was he assessing for?
Oh, that flap. What's it called?
Yes.
The flapper for the palm, the jaundice in the palm.
Nope, he was doing the flapper. What's the name of that?
Ataxia?
Asterixis?
Yeah.
Okay, yes. It's like this, it's the liver flap. They kind of call it a bird flap, right? So they hold their hands upward for a few seconds and they have this involuntary like flap going on. Yep, that's one way to check for it. Okay, so our patients have ammonia. They're skyrocketed. You can see these patients, like, again, smelling them. You can really, like, walk into a room, smell, and you're like, boy, I bet your ammonia is pretty high. So how can we bring ammonia down?
Lactulose.
Lactulose. Has anybody ever given lactulose? It's kind of
Not given it, but dealt with patients that are on it.
Okay, Tyler, what happens?
Poop their brains out.
Yes, they do. Yes, yes, yes. Okay, so they're excreting that ammonia out. What is the purpose of lactulose?
It's to decrease the amount of ammonia in the
Okay, and then in order to what? So we're decreasing that ammonia. Why? We want to
basically increase cognition because of those ammonia levels.
Yes, yep, improve that cognitive function. Yes, great, 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 great.
And just a quick question, this is a side note, is the breakdown of albumin, is ammonia the byproduct of that? Just so I can write that down, I can Google it, I guess.
Ammonia is created by the breakdown of proteins, and the liver takes and breaks that into urea, and you excrete your kidneys.
Right. Gotcha.
Good.
I thought so. I just wanted to clarify.
All right. Good, you guys. I feel so happy you guys are doing good. All right. So let's keep moving on then. Liver transplant, again, that's pretty like the end stage, right? Big thing to watch. These patients can reject the liver transplant. They're very, very hard to come by too. All right, education, we talked about that, the avoidance of alcohol. I'm just gonna keep flipping through, guys, okay? Alcohol withdrawal. Okay. You guys can read about those a little bit. Anybody see anybody going through an alcohol withdrawal? No? Okay, some are shaking yes.
Yeah, I have in the hospital.
Okay, what did you see with them?
They're diaphoretic, very sweaty.
Okay.
They can have fevers.
Yep.
Shaking really bad.
Yeah, when they go through DTs really bad, they shake. Just not good. Doesn't look good.
No, they pretty much sleep it off too. You look at them and they're kind of in the fetal position.
Yeah.
Yeah, it's pretty bad.
Do they have mood swings too?
They can. Yeah. Happy, sad. Come at ya. Okay, so I was going to talk to you guys a little bit. Let's end a little bit here with the DTs. I had a patient. The floor that I worked on was a med-surg floor, so it was kind of the dumping ground, so to speak, right? So we had a lot of alcoholics coming in, and we would have to give them that banana bag, kind of recheck their blood alcohol level every 12 hours. And then once they got below, then we finally could let them go home. But what I experienced with some of these patients, I'm going to tell you a couple of them. One, he was ready to go home. We gave him his discharge papers. All of a sudden I heard a sound. It was a sound that I will honestly never forget. And it was just like a watermelon hitting the ground. And I was like, oh boy, where did that come from? So I went running into the room. He was like back in the corner, room like 79. And he was on the floor having an active seizure. He got up, he was ready to leave. We were detoxing him, stood up, ready to walk out the door, no IV, nothing in him, and he fell like hard, right on his head, bleeding. There was blood everywhere. So like I was underneath him, but rolled him on his side, right, with the seizure and finished it. So that was one case that I saw. He had DTs. He was going through it pretty bad, and things were not right with him. So they stitched him up, needless to say. He stayed for a little bit, and we had to figure out what was more wrong, right? What was happening. So that was one instance that I saw pretty bad with a patient going through detox. Another one, I had just come in for a report. This was pretty bad. I got like my 5 patients. We went around, walked around. This guy, he was so agitated. He was like late 40s, early 50s. He was in his room just pacing all around. And the night shift nurse had reported to me that, yeah, they found him about 3 a.m. He was in this poor little old lady was in a room next to him, found him underneath her bed. He was a mechanic. So he was underneath her bed trying to fix the car. That's how bad he was detoxing right now on us. So they had to bring him up. Like he literally had screws loose too from the bed. Like he was going to town underneath this poor little old lady's bed. So we brought him back. He started to get really, really agitated with me to the point where I was afraid to even be in the room with him alone because like he was in my face, screaming. He was going through DTs so bad that I had called his primary care. I said, listen, I can't be in this patient's room. I have like 4 other patients, right? Like he's a one-on-one. There's no way. We have to do something with him because we were giving him everything, any kind of psych drug you could think of to try to calm him in. The man, nothing was hitting him. So do you know what we ended up doing? Can you guys think about what would be what do you think happened with him? What do you think I ended up doing with this man? He was
Like,
so bad.
Either one-on-one care, so there's a sitter in there with him, or I don't know, restraints.
Okay.
Had to send him to psych.
Okay. He wasn't stable enough. Couldn't send him to the psych unit, mental health yet.
A sedative?
Okay. We were giving him everything underneath the book and nothing was touching this man. Do you know what I ended up doing with him? I sent him down to the critical care unit and we put him in an induced coma to get him out of this DTs. That's how bad this man went through it. I remember this one completely, like this was my first out of like 14 years as being an RN that I've ever sent a man down induced coma to get him out of his DTs. That's how bad this man had it. So yeah, that was kind of a pretty interesting story. So it can happen. Just to let you guys know, just a little story. All right, let's give you guys a break. And then we'll move on to the pancreas and gallbladder. Sound good? Potty break, coffee break. What time you guys want to, I'll give you guys 10 minutes. How about 10:33, 10:35? We'll meet back, okay? All right. All right, you guys ready to move on to the pancreas? Did you guys see on e-learning, I have a pancreas case study on there for you guys to look at? Okay, let's put you guys in groups again, okay? Let's do that and let you guys work on that case study and then let's come together as a group and talk about it, okay? Get you guys exercising your brains a little bit. All right. All right, so start the case study of the pancreatitis, okay? Melissa.
No big deal. We would have got done though.
Yes. Okay. I'm going to share this with you guys, okay? All right, so we had this gentleman come in, right? Quite a bit happening with him. So based on his presentation, Tell me a little bit. What was happening? What's his disease?
Acute pancreatitis.
Acute pancreatitis. Okay. So what is acute pancreatitis? Okay, so we know itis is what?
Inflammation.
Inflammation.
All right, so anytime you guys see the word itis at the end, okay, so it's an inflammation of what?
The pancreas.
Pancreas. Okay, so his pancreas is inflamed. All right, so what do we know about the pancreas, guys? What does the pancreas do? What's the function? There's two major functions.
Insulin secretion.
Okay, helps to regulate those blood sugars. Somebody else.
Digestive enzymes.
Correct, yes. So it helps in digestion. It makes this pancreatic juice, the enzymes, to break down what?
Carbohydrates, proteins, fats.
Sugar, starches, yes, good. Okay, so the two major functions, they help in digestion and they help to regulate that blood sugar. Good. Okay, so with our case study here, what signs or symptoms characterize this disease? So what did he present with? What did we see happening with him?
Abdominal cramping or pain, fetal-like position,
Okay.
diaphoretic pale.
Diaphoretic. So they kind of sometimes too go into this like hypovolemia. And what do we know about hypovolemia? What are some of the symptoms of hypovolemia?
Hypotension, tachycardia, and tachypnea.
Okay, so pulse pretty high. They can have like a low grade fever with that. Yes, hypotension. All right, so they kind of go into that with acute manifestations here. What else, guys? How about his abdomen? What was going on there?
Sharp knife-like pain. He was guarding it.
Okay.
Curled in the fetal position.
Okay, so pain, where was his pain? What did he say it was?
In his abdomen that radiated to his back.
Yes, yep, so pain radiating to that back, yes. How about his bowel sounds? What was happening there?
Hypoactive.
Hypo, so they're kind of decreasing, right? Decreased bowel sounds we're hearing. Okay, and then what else? What else was another sign? Yeah, generalized.
Edema.
Let's look here.
Here.
Like jaundice, right? He had some jaundice starting, but he had a, all right. All right, so looking at him, what lab values represent acute pancreatitis?
WBCs.
Okay, but that's like a sign of infection. What would we look at for acute pancreatitis, specifically pancreatitis?
Amylase and lipase.
Okay, what happened with the amylase and lipase?
They increase.
Increased, yes. So we have an increase of the amylase and lipase. What else is increased with acute pancreatitis would we see?
Glucose.
Yes, glucose. Glucose is pretty high with these patients. Okay, so what's a lab value? A lot of this is inflammation, right? We have, or increased, I should say, amylase, lipase, glucose, WBCs. What's one lab value that we would see decreased?
Calcium.
Calcium. All right, so usually these patients, when they come in with acute pancreatitis, we see increased lipase, increased amylase, increased glucose, and we're gonna see a decrease in their calcium. All right, so he tended to have all that, correct? You guys would all agree? Okay. Moving on then. Okay, so he gets up to the floor, he's admitted. You guys have him, we're gonna call for some orders. So we call Dr. Ahmed. We say, hi, I have your patient, Mr. C here. He came in, his amylase is high, lipase is high, glucose is high, his calcium's this. complaining of pain. It's radiating to the back, quite a bit of pain. He's in the fetal position. What else could we tell him? I shouldn't have done this. I should have made you guys call.
Nausea and vomiting.
Okay. What else? How about increased pulse? His pulse is this. He's got a low-grade fever happening. All right, so he tells you, what orders do you think he would give us for patients coming in with an acute pancreatitis?
NPO status.
NPO, right. Give him nothing by mouth. What if he says, I would like some ice chips?
No.
No, we don't want to give him anything, do we? Nope, nope, no. Okay, so we're keeping him NPO. He can't live like this, right? We got to wait for that pancreas, that inflammation to calm down. So he can't go very long, right? Because also, doesn't he have acute renal failure going on? So we keep decreasing, not giving him anything. What orders do you think this physician's going to tell us?
Insulin? Or no?
Yes, they would probably put him on a sliding scale. We're going to check his insulin, right? But if we put him on a sliding scale, he's eating nothing by mouth. What's going to happen if we give him insulin?
He's gonna bottom out.
He could bottom out, right? Yep. So monitoring that is important. What else should we do with him?
So you would put him on an NG tube if applicable, maybe some parental feedings that way, but you would also get an order for TPN or PPN.
Okay. Yep. Some of these patients.
Increases fluid through IV.
Yes, that's a big thing, you guys. These patients come in with acute pancreatitis. We usually, as an RN, how we would care for them is we keep them NPO, nothing to eat or drink, no ice chips. And then the physician's gonna say, let's order like normal saline, let's run it at 150 to 200 an hour. So that's quite a bit. So what do we know when we're gonna run IV fluids that fast?
You want a large gauge needle?
Good, you guys. Yes, we want to look at the gauge of the needle and make sure it's capable of withstanding that IV pressure, right? That fluid. Good, good, good. You guys are making me happy. Good job. Okay, bed rest too. We want rest. These patients need to bed rest, NPO, NG tube if need be, increasing those fluids. We just need to calm everything down. Okay. Moving on then, number 3, what is or are the priority nursing diagnosis for Mr. C? What should be our first one? What do you think? Pain, yes. Fetal position, he's in quite a bit of pain. So pain. What else?
Electrolyte imbalance?
Yep, let's look at those. Imbalanced nutrition, good job. Looking at all those electrolytes. Good, good, good. And then comfort, right? Measures all that. Great, great, great. Okay, what interventions? Okay, so we did our nursing diagnosis, right? Pain, nutrition. So what intervention should we initiate, monitor, prevent? What else? What should we do? What interventions? You as a nurse, what are we gonna do?
Administer pain medication.
I'm sorry, say that again, Dwayne.
Administer pain medication as ordered. And it's going to be IV.
Good, yep, administering that pain medication. How about nausea? Any antiemetics? Yep, give them anything for the nausea, vomiting, because that can all go hand in hand together. Making sure he's NPO. All right, giving
Educate
TPN.
the importance on staying NPO and not sneaking off to the bathroom and drinking water from the sink.
Oh, have you had this, Melissa? Yes, you see them underneath. Oh, it's great. Good. Yes, yes, yes. All right, major outcome. What do we expect to achieve with this patient? The very end, when would we discharge him, do you guys think? What's our outcome? What do we want?
Once the inflammation has subsided and we have advanced his diet from starting from clear to regular diet.
Dwayne, how do you know this?
Oh, I don't know. Probably because I had a patient.
Okay,
at Covenant with acute pancreatitis.
good. So explain to the class about him.
So
How old
he,
was he?
young, 35.
Right.
He was like 23, 24 when he was diagnosed with pancreatitis. He said that he had drank a lot and basically he will have this forever for the rest of his life. And he comes in and out of, he has exacerbation of pancreatitis. So he was on pain medication, NPO status. At one point in time, he had a peg tube placed because it got so bad. So they just basically they stop all food, give the bowels a rest, and then they start back from clear liquids, working up slowly. And if they don't tolerate that diet that they advance to, then they back down, and then wait a while, then restart trying to re-advance it again.
Yes. So how long was his hospitalization, would you say, with pancreatitis?
I think he was there for a week.
Right. See how long these patients can be in a hospital setting with acute pancreatitis or an exacerbation of pancreatitis, all of that happening. So these are not fun for these patients. Good, 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 good.
And then the amount of pills we had to give him.
Right. And what was he taking?
He was taking a lipase supplement.
Okay, and that was for what?
To help break down the fat that he would ingest.
Okay, and when did we administer this? Would you administer this?
Every meal.
Every meal. So he was taking how many pills? But that was just the hospital because they didn't have the high dose of it, but he was on quite a dose, wasn't he?
He was like on what, 15 or something like that we had a scan in.
We scanned in 15 of these pills for him every single meal. Yes, it was quite a bit for him. Good. Any questions for you guys? Any questions to Dwayne about this patient? It was pretty interesting, wasn't it?
It was interesting and sad. Like,
yeah,
for somebody so young.
And it's going to be life now, lifelong for him. Yes. Okay, so what learning or teachings do we need to anticipate? All right, so Dwayne, your patient was discharged. You guys, as an RN, let's not pick on Dwayne anymore. Let's pick on more people. What would you guys think about, or what would we do for discharge instructions? Some teachings for him.
Teach them about their diet, so like low fat.
Good. Yes, avoiding those high fat foods. So a low fat diet. Good. Good, Erin. What else, guys? There's like 4 major ones that we should talk about with them. So we got 1.
Avoid alcohol.
Alcohol. Yes, avoid alcohol, because we know alcohol can exacerbate, create acute pancreatitis. Okay, what else? 2 more. What brought him in the first place? What's a big priority?
So to keep monitoring for signs and symptoms.
Of pain, yes. If he starts developing any more of this pain, unrelieved abdominal pain. And then another thing they say is to avoid heavy lifting with these patients. Okay, so everybody feel good about acute pancreatitis? Our little case study here with this gentleman. Yeah, okay. So those are the big things to kind of take away from acute pancreatitis. So go back into your slides then, and let's move to chronic pancreatitis. I'll give you guys a minute. Okay, so when we think of acute, it's prolonged, continuous, prolonged. It's fibrosing the process of the pancreas. Big things behind this again is alcohol. We have gallstones that can create this. You can get pseudocysts. It can be an autoimmune disease such as lupus, cystic fibrosis. Usually acute can turn into chronic. And then idiopathic. And when we think of or see the word idiopathic, like this could be on even NCLEX. What do you guys know about the word idiopathic?
Isn't it usually like no known
No
cause?
sign.
Unknown. Yep. So when you see the word idiopathic, think unknown. Okay, so let me talk about, let's keep going, some characteristics. How do these patients usually present? Again, you're gonna have pain. They can have diarrhea, this oily, fatty stools, which have such an odor to it, you guys, with this pancreatitis. And think about that, because it's not breaking down, right? So their stools get quite malodorous. Weight loss. Alrighty. So some non-surgical, again, with these, we treat with drug therapy. We give them those enzyme replacements, which Dwayne kind of touched on with, I want to say it's called Creon. It's like a mixture of like the pancreas, lipase. It's got like a mix of it all in there for medication. Insulin therapy, nutrition therapy. All right, so some nursing teachings, education. What should we do again with these chronic? They're almost hand in hand, same with acute. So resting, avoiding any type of alcohol beverages, because this is going to be chronic. So nothing. All right. Then we move into like pancreatic abscesses, which honestly I haven't heard or seen much of these, but it can be filled like purulent pus inside of the pancreas. It's a serious complication, high fever, they get abdominal pain, nausea, vomiting. They usually put a drain in. Antibiotics treatment alone does not work to do this, so they have to drain these abscesses. All right, pseudocyst, again, not really hearing much or seeing a lot of this, but a collection of that fluid rich in the pancreatic enzymes, blood, and necrotic tissue. These are usually the complication of pancreatitis. How we treat these patients, rest, IV fluids, again, the pain, nausea, medication. These all kind of go hand in hand. All right, then we move on to pancreatic cancer. All right, what do we know about pancreatic cancer? It's kind of sad what just happened, right? Do you guys remember who just passed away from pancreatic cancer?
Alex.
I know, yes. So Alex Trebek, right? He had that pancreatic
didn't
cancer.
answer that in the form of a question.
I know, what is?
Who is?
Yeah.
I should have.
You should have, Ty. Okay, so these numbers have changed quite a bit, right? I just looked them up this past year, like 57,000 get diagnosed with this each year. And 47,000 pass away, die from it. So that's a lot, right? It's almost like once you're diagnosed with pancreatic cancer, it's not very good. You have a 5-year survival rate once you're diagnosed with it. So when I worked with, in my master's, when I was continuing my education, one of the RNs that I worked with on my field study, she was in her 50s. She ended up getting pancreatic cancer. She was a really good nurse, and she passed away not too long ago from it. I know, pretty sad. What do we know about pancreatic cancer? Again, the etiology is unknown. Nobody really knows how or where, but you have risk factors leading to it, right? Chronic pancreatitis, that chronic inflammation, diabetes, age, just there, it's still unknown of how. How they manifest, right? The jaundice can happen, hypovolemia. Usually it's later though, like they catch it too late. When it's later, you're pretty much farther along. Then these symptoms start occurring farther along and it's too late. What else can I say? All right. Diagnosing it. Again, the PET scans, those are pretty much to see where it came from, if it's stage 1, stage 2, 3, 4. Nursing care again, like frequently. Okay, you guys can read it. Okay, have you guys ever heard of the Whipple procedure? It's kind of the last bit of the pancreas, the very last slide before we move on to the gallbladder, but Whipples?
Yeah, I've heard of it.
Yeah, okay. So Tori, what do you know about it then?
Well, I actually just looked it up. It's also known as the pancreatic duodenectomy.
Okay.
And it removes the duodenum, the gallbladder, and the bile duct.
Okay. And then what do they do? Like, what does the physician do then? He reconnects the remaining, right? Intestines, bile duct, and pancreas. It's kind of a crazy, it's very rare. I've seen it once at McLaren since I've been there. And a lot of the physicians, unless they do them over and over, a lot of them don't really do this as much. Okay. So yeah, just kind of know that there is a procedure, but survival rate again is pretty low. Okay, everybody feel good about the pancreas? Yay. Okay, so let's move on to the gallbladder. We can move pretty fast. We'll get done earlier than expected, okay? Then you guys can keep studying. Okay, gallbladder. What do we know about the gallbladder? What is the gallbladder? This was on Jeopardy last night too, if you guys watched it. What does gall mean? This was a question. I was like, oh my goodness.
Isn't it storage?
Nope. According to Jeopardy last night, it was not. Anybody know?
Nope.
Okay, gall means bile. Go figure, right? So bile bladder. Okay, so the gallbladder, what does it do then? It stores bile, right? Produced by the liver. So after meals, the gallbladder is empty and flat, which this is amazing. It's like a balloon. Before a meal, the gallbladder may be full, like full with that bile, and it's usually the size of a small pear. So this helps with digestion. So you guys all came from med-surg floors, right? Did any of you guys get to deal with gallbladder issues? Cholelithiasis, a cholecectomy, cholecystectomy?
Nope.
Nope, nobody did. Nobody got to see anything.
I did.
Tori did. Good. Okay, Tori. Let's talk about your little lady here, right? What was happening with her?
So she came in with right upper quadrant pain, just nausea, vomiting. She was found to have gallbladder stones. So she had those removed.
I'm going to stop you. When we hear stones, what do we know? What's the word for stones?
The cholelithiasis?
Cholelithiasis, yes. So when you see the word lithiasis, this is kind of helping you guys, because if you guys are on exams, even your NCLEX, when you see lithiasis, it kind of means stones, because you might see this back in kidney too. You'll see nephrolithiasis. So you're going to see kidney stones. Okay, so when we see a cholelithiasis, it's stones in the gallbladder. Okay, keep going, sorry.
And then the next day, she ended up having her whole gallbladder removed.
Okay, what else was happening with her though, remember? It was like a weird name. She had the gallbladder removed, and then didn't she have a choledua? They had the D in it, remember?
I can't remember. I know she had the ERCP, but I don't remember what else she had.
She had didn't she have part of the bile duct as well? There was a stone in there?
Oh, yeah. Yeah.
So it was like
if I had my paperwork, I'd know.
Right, it was like a choledectomy or something. I had the D.
Yeah, choleduodenectomy. Yeah.
Duodenectomy. Yep. Okay, good. All right. So what was some of her symptoms? You said the right
Right upper quadrant.
Okay. Any lab values?
Yeah, she had elevated AST, ALT, and then the amylase and lipase and white blood cells.
Okay, so she had quite a bit happening, right? Inflammation happening, cholecystitis. All right, good. So what, after surgery, how did you care for her? Or how would you have cared for her, you guys? So she had her gallbladder removed. Tori, what did her incisions look like? Usually with gallbladder.
They were just like little portal sites, if I remember correctly,
So
right?
it was laparoscopic, right?
Yeah, laparoscopic.
They tend to call those stab sites. So how many did she have? She had 3?
I don't remember if I had a dressing over it, but yeah, it was only a couple.
Okay, yeah. Usually there are about 3 stab sites. One is the umbilicus, and then they go 2 like on each side, kind of looking for. One, they put a camera in, they fill it with air, and then they go in and remove it with the other one. So when our patients come back, what can be a big complaint with patients when they kind of have that air inside their abdomen here? Anybody really know?
Is it back pain?
Not really pain. They complain. It's pain, not back pain. It's pain. So they do
But it's
complain
like
of that
pressure.
abdominal pain. Pressure.
That's what
Yes.
she was saying. Yeah, pressure.
Yes. So how can we relieve that? What do you guys think we should do with our patients that just had surgery? Say it, Caitlin.
Ambulate.
Ambulate. Yes. We want them to get up, walk, get that gas out. That helps relieve that pressure. Okay, what else do we know about people, individuals that have surgery? What else should we be doing with them? I'm drawing stuff in.
Monitor vital signs every 15 to 30 minutes.
Okay.
Bowel sounds.
Okay, but what's another big one? Surgery, guys, surgery. What do we want to prevent? Say that again?
Infection.
Okay, keep going. It's very important. Any type of surgery.
Breathing, cough, and deep breathing.
Breathing, good job, Tori. Why?
Pneumonia and atelectasis prevention.
Good, yes. So getting them up, getting them ambulating, cough and deep breathe, preventing that atelectasis. Great. Okay. I'm gonna keep moving on then. Cholelithiasis, clinical manifestations. Again, your patient, Tori, you were a prime example. They come in with that right upper quadrant pain, sometimes this right shoulder pain as well. So those are like your number one sign. These patients are like, yep, got that pain on the right side. I better go in. It's 95% of the time it's your gallbladder. Okay. How we diagnose. They usually have this increased white blood cell count, right? Infection. They have this increased serum bili levels. Do you guys know the normal bili levels? Roughly. These are good to know. Good to know for your test. Okay, the norm is usually 0.2 to 1.2. Roughly. Every place is kind of different, but let's go with this for now, okay? They would have an increased bili in their urine. They represent with increased liver enzymes, which is your ALT and AST, right? We just kind of talked about those. They can have an increased amylase, which amylase and lipase go with what? What organ?
Pancreas.
Pancreas, yes. All right. So that's the diagnostic test for these. Okay, sometimes we can do an ERCP. We briefly touched on this last time too. Do you guys remember an ERCP?
Yeah, kind of. I read about it. I remember it was like a combination of like 2 things, X-ray and...
Yep, they go down with the scope.
Yeah.
Dwayne, are you trying to talk?
Dwayne, help me.
Look at him. He's
Endoscope, retrograde, Chole something.
Cholangio.
That's a good one.
Cholangiography. Okay, so they go in, look at it. What are they trying to do with an ERCP here? What do you think they would do with a patient that has a cholelithiasis? Think about what's happening. Lithiasis is what?
It's looking at the gallbladder,
Okay.
pancreas, and liver.
Okay. So lithiasis means, just talked about it.
The gallstones.
Stones, yes. So if we're going in ERCP, going down, using like fluoroscopy with that, looking at it all, what do you think they're going to try to do with an ERCP before they do any type of invasive?
NPO.
Okay. What's the purpose of an ERCP? Why are we doing it?
See the size of the stones?
Okay. Sometimes too, how about they go in and try to extract it? Remove the stone. Those are so hard to do, and so many gastrointestinal physicians have such a hard time doing these. It's kind of a rare occasion, but that's the purpose. Go down, try to remove it.
So it can be
Usually in the duct.
diagnostic and for a treatment?
Yeah, yeah.
Yeah, because I think my patient, she had 2 of them that were successfully removed.
Good, so she had stones there. It's usually found in the bile duct.
Yeah, in her biliary duct. That's where they were found.
Yep, yep. Yes, good. All right. Great, great. All right, let's keep going then. When you guys keep going, okay, so collaborative care, the cholelithiasis, when you see a lithotripsy, because you're gonna see this word come out too, lithotripsy goes hand in hand with the cholelithiasis, with the stones, right? When we look at the word lithotripsy, it's a shock wave. So it's these high energy shocks and it disintegrates those gallstones. That's the purpose of this. When you see a lithotripsy treatment, you're gonna see this come up too with kidney stones. With urology, they would do a lithotripsy with them, try to blast the stones, and then you would just, it would just come out, excrete it out. Okay, so cholelithiasis. We talked non-surgical treatments, again, low-fat diets, fat-soluble vitamins once they've had them. All right, drug therapy with pain. Surgical treatments, again, we talked, they get that laparoscopic, which Tori's patient had. Standard pre-op, it's NPO after midnight, consent signed. Post-op care, right? We talked about getting them up, getting them ambulating, cough, deep, breathe. We don't want any respiratory issues. There's that free air pain that we talked about too. So ambulation is so important with these patients. And then usually these patients, when we discharge them too, we can say home, no heavy lifting. I used to tell my patients nothing heavier than a milk jug. That's how they can all relate to it. No bending, twisting. They got to keep it pretty simple for a while. Okay, then let's move into this transhepatic biliary catheter. Did any of you guys have any of these with your patients? Didn't Tyler have one? Is he gone? Didn't your patient have a?
I'm here. He had a drain, yeah.
Was it a T-tube?
It was a T-tube, yeah, that was hooked up to a little bag that drained all of it was out of his gallbladder.
Okay, so what do we know about a T-tube?
Like it just sits in there basically and continually drains.
Okay, yes. So how do we manage that? How did you manage it? Like, is it something that should hang down?
No, I pinned it up to his gown so it wasn't putting like resistance on the sutures where it was at.
Okay, so usually keeping it up above the abdomen, close to his abdomen.
Yeah. kind of let gravity do the work too.
Okay.
No, or
Do we clamp him?
no.
No, right. So these T-tubes usually are not clamped unless we have an order, but usually they're not clamped. How about irrigating? Think we'd ever irrigate a T-tube? No, usually we don't. Nope.
Just watch the output.
Yes. So what if there is no output?
That's probably a problem because there's some sort of obstruction.
Good. Yes. Yes. These are all good things that we need to be aware of when our patients have a T-tube. Yes. So they should be having output. If there's no output, we have to let that physician know there's no output going on. Good. All right. It's not clamped. Usually don't irrigate these. They just kind of hang off to the side. Yep. Great. Okay. Collaborative care. You guys can kind of read these. Okay, let's talk nutrition. So we have our gallbladder removed, right? A cholecystectomy. So what kind of diet should we be teaching our patients that have these? Nutritional therapy.
Limit the amount of fat.
Yes, so a low-fat diet may be helpful in that flow of the bile, if that flow of the bile is reduced. So this usually only is an early post-op care, post-op patients in that period, or if the patient is overweight. So we want to give them that low-fat diet. Okay, sometimes the patient too is instructed to restrict that fat for 4 to 6 weeks, taking that fat out. And then avoiding that excessive fat intake. Yeah, so a lot of this has to do with like the low fat, no fat diet. Good, 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 good. All right. Some management pain. You guys can kind of read over those because we talked about that. Okay, this is another good one too. Let's move on to cancer of the gallbladder. Dwayne, didn't your patient have something? Like you guys got to see a lot of this, which is amazing because this was all brand new to me. Because have you guys ever heard of cancer of the gallbladder? Truly. I have not, honestly. This was the first time that I've actually seen a patient, was Dwayne's patient with it. So go ahead, Dwayne. I'm gonna let you talk about it a little bit.
So he had the rare of the rare condition. So I can't remember, the tumor started with a K, but it was a tumor that surrounded his biliary ducts and the liver and around the gallbladder. And so he couldn't like release any bile or anything like that from his liver. They had to go in and they had to put in these drains in his biliary ducts. Yeah, it was crazy to see. So he had one that was in the middle of his stomach, and then the other one was on the right side of his stomach.
Right, I'm trying to look at the name of it. It was rare. Wasn't one on the branch or on the duct that was like blocking it? So that was what was causing his obstruction? That's what was making him so yellow?
Yeah, there was like a tumor that surrounded the
common bile duct.
Yeah.
And that's obstructed it. So that's why this man, and Tori didn't believe us when we talked to him, like, Tori, you need to turn around and you need to look at this man and you need to see jaundice in its true colors. Tori,
yeah, that was really bad. Like, it sounds really like kind of mean, but I swear, like, it looked like Homer Simpson yellow. Like, I swear, it was so bad.
Right. Yes, he was quite jaundiced because of that backup. So yeah, but again, this is rare. This is the first time that I've ever seen anybody have cancer of the gallbladder. Yes. The primary cause, again, it's uncommon to have that gallbladder, the site. So what was his primary cause of it? Where did his cancer originate from, Dwayne? Do you remember?
I don't remember.
Wasn't it the liver? Didn't he have liver lesions? So. Yeah, liver lesions that came into the gallbladder. So usually the gallbladder is not primary. Yeah. All right. Okay, you guys, any questions on gallbladder? No? Are you guys pretty much drained? Okay.
I'm hungry.
Okay. Do you guys want to call it a day? I mean, I don't have.
I am cool with that if everyone else is.
I'll let you guys read it over again. We went through, we touched on a big things that we need to. We did a couple case studies. Sound good? I'll let you guys finish up. We can meet again. You guys, we're not together next week. You guys get kind of a week off, right? A little bit. We finished clinicals, which honestly, I think we are the only group that did it all of us, talking to the rest of the clinicals. Even your other section of this, they were off a lot of it. Jessica got quarantined. Yes. So you guys consider yourselves very, very lucky that all of us got through it.
Good deal.
It was. Everybody that had the hepatic medications, please send them out to me. I can get them out for you guys. You guys can work on that quiz if you want to, get it in before. But I know I gave everybody till this Sunday to give it to me. But next week, study. Get that exam, the quiz on the 30th. And then that Evolve case study is going to be December 1st. We'll do the Zoom at 10 that Tuesday before. We'll take our exam on Wednesday.
Okay, so we don't meet back again to the 1st.
Correct. Yep.
Zoom's going to be at 10?
Yep. Our exam is online again. So we'll have 9 to 11 that Wednesday. So I already started a thread too. I started it with, to get us kind of thinking too on the sim quiz. I put a discussion on there. So you guys can start looking in there too. So we'll have a sim, like a student quiz, like a student study guide on the 7th. We'll do that at 10. And then your sim quiz is due on the 8th. And then December 10th, we'll do like our final student study Zoom. We'll do that one at 10.
Hey, question. Is this sim quiz going to be timed?
I'll give you enough time on it.
Like 3 hours?
It's 30 questions.
4 hours?
No.
I'm nervous, man. Some of us are like right on the wire here. I mean, we're doing good, but then you're going to throw this crazy sim quiz at us. And
You guys know it. You do.
That
I
quiz
promise you do. What's
goes
that?
into the quiz goes into the assignment points, not the test points.
Right.
okay,
Yeah.
that makes me feel a little better here.
Right, that's part of your quizzes. And looking at it, it's all of the stuff that we did, like we talked about, right? Chest tubes, trachs, all that. You guys should know those pretty good.
NG tube, man, just slap that baby in.
How?
Yes.
Back and throw it like a dart.
Yeah, there you go.
That's the way.
Okay, then our final is the 14th, and that is on Zoom as well.
Hey,